This case study is on cardiogenic shock. So, quick background. Shock is a syndrome characterized by decreased tissue perfusion and impaired cellular metabolism that results in an imbalance between the supply and demand for oxygen and nutrients. Cardiogenic shock occurs when either systolic or diastolic dysfunction of the pumping action of the heart results in reduced cardiac output. So, for the S bar, the situation, LV is a 68-year-old male who is 10 days post the acute phase of cardiogenic shock. His background, LV presented 10 days ago with an MI. He has a history of 2 additional MIs in the last 5 years, obesity, hypertension, and sleep apnea. He had chest pain at home for 12 hours before seeking medical treatment. His assessment, upon admission, his vital signs were stable. His heart rate was 93 beats per minute. His blood pressure was 130/70, respirations were 24, and OT was 93% at 2 liters per minute. Heparin infused at 1200 units per hour and IV nitroglycerin at 10 micrograms per minute. 24 hours after admission, he appeared restless, but oriented ×3. He began showing signs of being in the compensatory stage of cardiogenic shock, including increased heart rate, 110, increased respirations, 24, hypoactive bowel sounds, crackles in the lungs, and pale, cool skin. He quickly began to deteriorate into the progressive stage of shock. His blood pressure was 84/50, heart rate jumped to 132, respirations jumped to 30, his temperature was 96.8, and his O2 dropped down to 89. The HCP was notified and LV was ordered 40 milligrams of furosemide, IV stat, dobutamine IV at 10 micrograms per kilogram per minute, and dopamine IV at 5 micrograms per kilogram per minute. He was placed on a 12-lead ECG, and nitroglycerin was discontinued due to his blood pressure being less than 90. The HCP inserted a pulmonary artery flow-directed catheter, an arterial line showing an increased pulmonary artery pressure at 55/22, an increased pulmonary artery wedge pressure at 25, decreased cardiac output at 2.2 liters per minute, and cardiac index of 1.5 liters per minute. His blood pressure read 80/40, and his heart rate was still at that 132. The HCP ordered another dose of the furosemide at 80 milligrams IV stat. LV responded to this, and his pulmonary artery wedge pressure decreased, but 3 hours later, his condition continued to deteriorate. This included a decreased level of consciousness, decreased urine output, and respiration dysfunction. ABGs were drawn and showed uncompensated respiratory acidosis. His pH was 7.28, his carbon dioxide was 55, his PaO2 was 60, and his bicarb was 25. He was placed on a ventilator, and the HCP decided to insert an intra-aortic balloon pump for circulatory assistance. Due to prompt intervention, he has gradually weaned off this balloon pump. He's weaned off the hemodynamic medications and ventilator over the period of 10 days. So my recommendation for LV to prevent further progression of coronary artery disease that could exacerbate another MI, the patient should be on a low-fat, low cholesterol, and no salt added diet. Home healthcare nurses can monitor his medical status and provide instructions to prevent a recurrent MI. Physical therapy, occupational therapy, and home health care will be needed to help return LV to normal ADLs, and a discussion with his healthcare provider may be needed for strategies to prevent cardiogenic shock. So, for instance, CRT is the placement of an extra pacing lead in the coronary vein of the left ventricle. It coordinates contraction and enables synchrony between the right and left ventricles and increases cardiac output. Heart transplantation is also an option with patients that have had cardiogenic shock and could also be included in this discussion with his healthcare provider. So the intra-aortic balloon pump, it's inserted to provide temporary circulatory assistance to the patient who had this MI and this injured myocardium, giving it time to recover. The therapeutic effect of the IABP is to reduce afterload and increase artery perfusion. So I included this YouTube video. It's just an ICU crash course that just kind of goes over the basics of how the intra-aortic balloon pump works. Um, I'm not going to play it. I had to restart the presentation actually because for some reason the screen recording won't allow me to play the YouTube video. But I have this presentation submitted. So if you wanted to take a look at the video, it just kind of is a quick 6-minute video that kind of just goes over this IABP. Oops. So there we go. It just doesn't play. So I'll just go ahead and move along. So next are the vital signs. This is just a quick chart that kind of just shows the progression of the stages of shock. So you can see upon his admission, his heart rate was 93, blood pressure 130 over 70, respiration 24, and oxygen 93. And it's quickly starts to deteriorate as he progresses through the stages of shock. And it ultimately, his blood pressure plummets down to 80 over 40, his heart rate increases to 132, his oxygen is at 89%, and his respirations go up to 30. So in the next couple of slides, I'll just kind of go over his signs and symptoms and the way that his assessment correlates to these stages of shock. So the compensatory stage of shock, sign and symptoms. He's apprehensive and restless. His blood pressure is 110 over 60. His heart rate is 110. His respirations jump up to 28, and his lung sounds have fine crackles. His abdomen is soft, and he has hypoactive bowel sounds, and his skin is pale and cool. So you can see that his blood pressure went from 130 over 70 to 110 over 60 during this stage. His respirations bump up to 28, and his heart rate also increases to 110. So during the compensatory stage of shock, the body activates compensatory mechanisms in an attempt to maintain homeostasis and overcome the increasing demands of anaerobic metabolism. So the compensatory mechanism is the activation of the sympathetic nervous system, which is stimulated by the decreased peripheral perfusion. So this decreased peripheral perfusion causes vasoconstriction and increases the heart rate, which you see it increased to 110. The respiratory rate also increases to compensate for the impaired gas exchange. And blood is also shunted from the non-vital organs, which causes that impaired motility and hypoactive bowel sounds. The patient's pale and cool skin results from the decreased blood flow as well. So cardiogenic shock occurs when dysfunction of the myocardium, and in this case, the patient's 3 MIs, and results in a severely compromised cardiac output. The clinical manifestations of cardiogenic shock initially mimic those of acute decompensated heart failure. So LV signs and symptoms that also mimic this decompensated heart failure include tachypnea, tachycardia, the fine crackles. The tachypnea and the crackles and the breath sounds upon oscillation occur to the pulmonary congestion that results from this low cardiac output, and his agitation could be from that impaired cerebral perfusion. So it's really important in this stage that we're really monitoring his signs and symptoms, and we want to see if this is a heart failure or if it's a very severe case and actually goes into that cardiogenic shock. So unfortunately with this patient, he does start progressing into that progressive stage of shock. So soon after that assessment, his blood pressure starts dropping to 84 over 50. His heart rate is 132. His respirations jump up to 30. And he has an 89% oxygen in spite of being on that supplemental O2. He has decreased urine output and decreased level of consciousness. And then eventually, once the arterial line results come back, he's being monitored through that arterial line. His blood pressure goes all the way down to 80 over 40. Heart rate jumps up to 132. So during the progressive stage, compensatory measures fail and aggressive interventions are needed to prevent the development of MODS. The patient's signs and symptoms of progressive shock included an increase of heart rate and respirations. His blood pressure decreases dramatically, and O2 was 89 despite that supplemental oxygen. As his shock progresses, he quickly deteriorates as his oxygen imbalance increases. He begins to show signs of critical progressive stage shock. So his blood pressure, like I mentioned before, plummets down to 80/40. His heart rate jumps up to 132. His urine output decreases, and he also has a decreased level of consciousness, which is very serious. LV's low cardiac output results in lowered cellular oxygen supply, which severely decreases his tissue perfusion. This decreased renal blood flow results in decreased urine output, and the cerebral perfusion is further impaired, causing that decreased level of consciousness. So as we can see here, um, the progressive stage, um, he has that severe decreased tissue perfusion, and it's ultimately affecting his level of consciousness, and he's going into that critical level of shock. So next are the labs and diagnostics. So kind of jumping back up to when he was first admitted, um, the labs that were taken during that time period were his troponin. So his troponin showed at a 5.2, which is very high, as the normal range should be less than 4.0. So troponin level in the blood is normally very low, so a rise to 5.2 is diagnostic of myocardial infarction or injury. So troponin is the biomarker of choice for acute coronary syndrome. So that's how they were able to diagnose that he was admitted with a heart attack. So the labs and diagnostics for when he enters that shock period. After LV started displaying the progressive stage of shock, the HCP entered a pulmonary artery flow directed catheter and arterial line. And during that monitoring, that's when we see the blood pressure and heart rate, and then also his pulmonary artery pressure. We see that that's high at 35/22. His pulmonary artery wedge pressure is high at 25. And then he has low cardiac output and that low cardiac index as well. So the increased pulmonary pressure and the increased pulmonary artery wedge pressure, plus the decreased cardiac output, indicate that the myocardium is unable to generate enough stroke volume to keep up with the venous return to the heart. So those hemodynamic medications that I mentioned in the assessment of the S-bar are needed to help the myocardium. Well, I guess to help the stroke volume. So when LV's condition continues to deteriorate after the medication, um, the signs and symptoms are including that decreased level of consciousness and urinary output. The ABGs are drawn. So we see that um, these results point to uncompensated respiratory acidosis. His pH and PaO2 are below normal, and his PoCO2, his carbon dioxide, is elevated, which indicates hypoxemia. LV is intubated and placed on a vent, and that intra-aortic balloon pump is also inserted by the cardiac team to provide circulatory assistance to LV's injured myocardium. So it's important to note that the pulmonary system is often the first symptom to display signs of critical dysfunction during the progressive stage of shock. So impaired gas exchange, decreased compliance, and a worsening ventilation perfusion mismatch can quickly lead to respiratory failure. So leading into the medications, kind of jumping back up to that MI, I mentioned these in the S-bar. When he got initially admitted for the MI, he was on 1,200 units of the heparin, which is an anticoagulant that prevents thrombi, and it's indicated for the prevention and treatment of an MI. And he's also on the 10 micrograms per minute of the nitroglycerin, which is a coronary vasodilator, which is used to prevent anginial attack, prophylaxis of angina pain, and heart failure associated with MI. So it's also important to note that this was discontinued when his systolic blood pressure was less than 90. So drug therapy for cardiogenic shock, the overall goal is to restore blood flow to the myocardium by restoring the balance between O2 supply and demand. and hemodynamic management of a patient in cardiogenic shock aims to decrease the workload of the heart. So the medications that this patient was on for his cardiac function during as he's progressing through the stages of shock, he's on that furosemide, starts at 40 and then eventually increases to that 80 milligrams IV stat. And this is a loop diuretic that decreases preload and that pulmonary artery wedge pressure and allows the myocardium to optimize contractility. So increased pulmonary pressure and low cardiac output indicate that the myocardium is unable to generate enough stroke volume to keep up with the venous return to the heart. So the dobutamine is 10 micrograms per kilogram per minute IV, and it's an inotropic medication specifically given to increase cardiac output. It's important to monitor the patient's heart rate and blood pressure during this medication because hypotension may worsen, requiring addition of a vasopressor. And dopamine, 5 micrograms per kilogram per minute. Um, it's a vasopressor that causes increased cardiac output by causing vasoconstriction in blood vessels. It's used in shock patients to increase perfusion. So the nursing diagnoses that I chose for this patient are decreased cardiac output related to inadequate cardiac pump effectiveness as evidenced by pale skin color, the increase in pulmonary artery wedge pressure, increase in pulmonary artery pressure, decreased cardiac index, decrease in blood pressure, increased respirations, and lowered O2 level. The second one that I chose has to do with this being his third MI, which eventually led to the shock. So ineffective health maintenance related to deficient knowledge regarding self-care and treatment as evidenced by recurrent MIs, waiting 12 hours to receive treatment for MI, and a pattern of lack of health-seeking behavior. So example, that history of obesity, hypertension, and hyperlipidemia. It's really important for this patient now that he's kind of weaned off of, he was very lucky and we were able to um, intervene quickly and he was able to make it through the progressive stage of shock without going to that last stage, which is very hard to come back from. So it's really important that we provide this patient with the tools and education that he needs to kind of get his lifestyle to be more conducive so that he can not end up in the hospital with another MI. So we really want to make sure that we help him with his self-care and treatment, and provide a lot of support to this patient so he can have a healthy lifestyle and try to stay out of the hospital. So educational points, I just wanted to bring up a few points of interprofessional and nursing care management for shock patients. So successful management for shock patients include identifying patients at risk of shock, integration of the patient's history, clinical findings, and physical exam to establish diagnosis. Since there's no single diagnostic study to determine when a patient is in shock, it's really important to make sure that we have a really good understanding of his history, and then those clinical findings, especially after an MI, that we want to make sure that he's not going into shock. And we also want interventions to control the cause of decreased perfusion and protection of those target distal organs. So general management begins with maintaining a patent airway and optimal O2 delivery. The initial nursing assessment focuses on the ABCs, and the nurse's role includes monitoring the patient's ongoing physical and emotional status, identifying trends and changes in the patient's condition, implementing drug therapy, evaluating the patient's response to therapy, providing emotional support, and collaborating with other members of the healthcare team to coordinate care. The patient requires a frequent assessment of heart rate, blood pressure, pulmonary artery pressure, neurological status, respiratory status, urine output and temperature, capillary refill time, and bowel sounds. All of these assessments are really important that we make sure that the patient isn't progressing into shock. And in this patient's case, yes, we just really want to make sure that we keep everything in check here. The overall goal for cardiogenic shock is to restore blood flow to the myocardium by restoring balance between O2 supply and demand. Alrighty, so I wasn't able to connect the concept map to the presentation, so I'm just going to quickly exit out of this mode and go over the concept map real quickly. So first I'll go over the actual map. So the concept map basically is a snapshot of what we've already gone over in the presentation. So I'm really just going to focus on this cardio respiratory section real quickly. So you're assessing the increases in heart rate, blood pressure. You're monitoring for signs of worsening conditioning or the worsening of the condition, so weakness, dysrhythmias, increase in tachycardia. The medications are the ones that we just went over during the presentation. And then these labs, again, so the cardiac output is low, the index is low, the wedge pressure is high, and the pulmonary pulmonary artery pressure is also high. And the rationale for this is the myocardium is unable to generate enough stroke volume to keep up with venous return to the heart. So the patient education and goal is to increase cardiac output and decrease pulmonary artery pressures and increase perfusion. So we want to educate the patient on lifestyle factors related to hypertension and obesity, and this should hopefully help him prevent from another MI that can exacerbate into cardiogenic shock. GI, so again, we assessed he had hypoactive bowel sounds, so that was going to be less than 10 per minute. So we want to continue monitoring for that worsening condition. We want to monitor for constipation because that's showing that there's decreased perfusion to the GI, which can slow down the motility, which kind of leads into the education for the patient. So we want to increase tissue perfusion and motility, and that's going to be as evidenced by normal active bowel sounds. For skin, we noted that the skin was cool and pale. This wasn't mentioned in the case study, but it's important to monitor for those signs of the worsening condition, including capillary refill being greater than 2 seconds, pallor, and cyanosis. And the patient education and goal is to increase perfusion, which is as evidenced by the capillary refill time under 2 seconds, the skin being warm upon palpation and appropriate for skin tone. Also, the patient demographics, so it's a 68-year-old male. His chief complaint was the MI. He was diagnosed with cardiogenic shock. His history was the 2 additional previous MIs within the last 5 years: hypertension, obesity, hyperlipidemia, and sleep apnea. Respiratory, we assessed crackles in the lungs, an increase in respiration, a decrease in O2 despite being on supplemental oxygen. We want to monitor for signs, again, of the condition worsening. So we're looking for increased crackles, increased tachypnea, labored breathing. The labs that were drawn were the ABGs. And during acute respiratory acidosis, the renal compensatory mechanisms begin to operate within 24 hours, which lead us into the renal section. We want to assess for decreasing urinary output. And the goal is to maintain adequate renal tissue perfusion as evidenced by a urine output of 1 to 2 milliliters per hour. And we can also monitor BUN levels, BUN levels. So for psychosocial, we really want to monitor the patient's ongoing emotional status, and we want to provide emotional support to the patient and caregiver. And we want to note any changes in mental or emotional state. For pain, pain was stable upon admission. So we want to continue monitoring for chest pain, which can be signs of another MI. The meds that he's on is the nitroglycerin. And the patient education and goal is to educate the patient on the signs of the MI, including chest pain that does not relieve with rest or nitroglycerin. And then finally for neuro, the patient first started appearing restless, which was kind of that first sign of decreased cerebral perfusion. And then as the shock started to progress, his level of consciousness decreased, and eventually the patient had to be put on the ventilator, which should probably also be mentioned in the respiratory section. And then the patient education and goal is to maintain tissue perfusion to remain alert and oriented times 4. So we really want to make sure that we are monitoring his level of consciousness, and any change in level of consciousness is a really big indicator that the shock could be progressing or coming back. So then finally, just kind of going to go up to the top here. So after a complete analysis, the priority patient problems are decreased cardiac output and that ineffective tissue perfusion related to that low cardiac output. How did the patient compare with the textbook? So shock is characterized by decreased tissue perfusion that results in an imbalance between supply and demand for oxygen. And cardiogenic shock occurs when dysfunction of the myocardium results in severely compromised cardiac output. So my patient's signs and symptoms, including his pale skin, those increases in the pulmonary pressures, his decreased cardiac output and decreased cardiac index, decreased blood pressure, increased respirations, and lowered O2 level match the textbook picture. Again, the nursing diagnosis is that decreased cardiac output, and the patient outcomes that we would work on during the clinical day would be: we want the patient to demonstrate adequate cardiac output, and that's going to be evidenced by his blood pressure being within the normal parameters. So I mentioned that he had that history of hypertension, so those might be a little bit higher than they would be normally. But when he first presented, he was pretty stable at that 130. So that's what I would think would be his normal parameter, but again, that would be indicated by the healthcare practitioner. We want his capillary refill to be less than 2 seconds, and we want his peripheral pulses to be 3+ bilaterally. In addition, we want his skin to be warm and dry upon palpation. So the patient will demonstrate adequate tissue perfusion as evidenced by normal active, which are 10 to 30 per minute bowel sounds, and urine output of 1 to 2 kilograms. It should be 1 to 2 milliliters per kilogram per hour. And then these are the nursing interventions that would be used to address the patient's problem. So I listed about 6 here, and these are basically going to be what we perform to make sure that the patient is demonstrating that adequate cardiac output, and we also want to make sure that he's demonstrating the adequate tissue perfusion by making sure that he has normal active bowel sounds and urine output. So these are the 6 interventions that I think would be particularly important to those outcomes. So that's what we have for the case study. And then I'll just quickly go here to finish the presentation. So finally, additional info that would be needed. There are several assessment factors that were missing from the case study that I think would have helped shape this presentation and the case study. So the first one is decreased cardiac output signs and symptoms. So while the case study provided most of the necessary information to complete the case study, the following details would be needed in a real-life scenario to help assess the cardiac system. So they didn't really mention the capillary refill time or the peripheral pulses. And these are 2 really important assessments that I would want to keep in mind, because as the cardiac output decreases, that hypoperfusion will result in the weak pulses, and the capillary refill time will also increase. And that's going to be showing that that tissue perfusion, basically that the cardiac output is decreasing. The second thing is the input and output. So the study mentioned decreased output, but did not give specific measurements. So urine output is one of the first indicators of ineffective peripheral tissue perfusion. Um, so it's really important to keep in mind or to make sure that we measure the output. So the healthy range is that 1 to 2 milliliters per kilogram per hour, and less than 0.5 milliliters is showing um, severe ineffective peripheral tissue perfusion to the kidneys. Um, the third thing is information on allergies and code status. The case study that mentioned if the patient had any allergies. So in a real life scenario, this would be a key component of patient care and would be dangerous to administer medication without knowing the allergy information. Um, Also, he did progress into pretty severe shock. So if he was a do not resuscitate and we were doing all of these invasive interventions and putting him on a ventilator, um, that would be against his wishes if he had a DNR. So it's really important to know that code status. And then also the time of assessments, example, they didn't really give any of the timing for when they took the assessments. And I would also like to just know the full vitals when explaining the shock progression. So for instance, when his blood pressure dropped to the 80 over 40, what was his oxygen level? And just having all of these assessments and the timing is really necessary for when you're trying to communicate to other people on the healthcare team, or if you're in shift report to another nurse, you want to be able to give them exact times, exact measurements, so you can really see how the patient is doing compared to his baseline, if he's getting better or getting worse. These are really important. And that is the conclusion of my presentation. I have my references here, and thank you for watching.